Hi everyone, welcome to the Emergency Medicine channel. Myself Dr. Ashik Envy, doing post-graduation in Emergency Medicine. Today let's discuss about postpartum hemorrhage. Let's start our discussion with the normal amount of blood loss in pregnancy. So the normal blood loss in normal labor is about 500 ml. For an LSCS, it is 1000 ml. For twin delivery, it is again 1000 ml. For cesarean hysterectomy, it is 1500 ml. Anything more than this is PPH, postpartum hemorrhage. Or in other words, PPH is defined as a drop in hematocrit more than 10% and need for blood transfusion. And blood transfusion is needed. This is also a definition of PPH. So basically, there are two types of PPH. Okay, we have primary and secondary PPH. Okay, primary and secondary PPH. So primary PPH is nothing but PPH within 24 hours of delivery. Secondary PPH is PPH in 24 hours of delivery up to 12 weeks postpartum. Okay, and the most common cause of primary PPH is uterine atony. But the most common cause of secondary PPH is retained tissue, that is placenta. Okay, retained tissue. So moving on to the etiology of PPH. Okay, it is 4 T's. The first T is tone, that is our atony. Second T is trauma. Okay, third one is tissue, that is retained tissue, and the fourth one is thrombin deficiency. Okay, so as the most common cause of primary PPH is atony, let us discuss about the causes of atony. Why or what are the factors increasing the chance for atony after delivery? Okay, causes of atony. The first one is multiple pregnancy. Okay, again polyhydramnios can also cause uterine atony because the uterus get enlarged in case of either multiple pregnancy or polyhydramnios. So there will be loss in tone of the uterus. Okay, prolonged labor. Okay, if there is a concomitant fibroid uterus. Okay, multiparity, all these factors will contribute to atonicity. So how can we prevent PPH? Okay, prevention of PPH. It is done by active management of third stage of labor. So let us discuss what are the components of active management of third stage of labor. So the first component is injection injection oxytocin 10 international unit, either IM or IV, within 1 minute of delivery. Within 1 minute of delivery. Okay. Or you can use other drugs like or injection methergin or tab misoprostol. These are the other options instead of oxytocin. Okay, the second component of active management of third stage is delayed cord clamping. You can delay the cord clamping by 1 to 3 minutes. Okay. The third component is controlled cord traction. And the fourth component is intermittent uterine tone assessment. Okay, uterine massage is no more a component of third stage active management. Okay, so let's move to management part of PPH. So for managing PPH, we should know the cause of PPH. So first step is assess uterine tone. Okay, it can either flabby or contracted. If it is flabby, the cause is atony or it is atonic PPH. Okay, if it is contracted, the cause can be either retained tissue or thrombin deficiency or trauma. So let's discuss one by one. So the first point is all patients within 3 hours of PPH give IV tranexamic acid. It is according to woman trial. Okay, so for thrombin deficiency, if the cause is thrombin deficiency, you can give factor 7A. Okay, for retained tissue, okay, give antibiotic coverage and do serial USG monitoring. In case of trauma to uterus, okay, for trauma, there is a chance for uterine inversion. Trauma can cause uterine inversion, and the uterine inversion can further leads to neurogenic or vasovagal shock. Okay, so the management of uterine inversion includes manual reposition. During manual reposition, the part which is come out first is replaced last. Okay, the part which is come out first is replaced last. And the other methods are hydrostatic method of reposition. Okay, so this is how you manage a case of uterine inversion. So now moving on to the most common cause of primary PPH, that is the management of atonic PPH. Okay, so for management of atonic PPH, so the first step is nothing but call for help. When you encounter with a case of atonic PPH, you have to call for help. Then go for symptomatic management. Okay, the symptomatic management include two wide bore IV cannula. Okay, you can collect blood for investigations. Arrange blood for transfusion. Flow for transfusion. You can start IV, NS or RL, and you have to catheterize the patient. Okay, moving on to the medical management. Okay, medical management of atonic PPH. So you can use either of the following drugs, either injection, oxytocin, okay, 10 international unit IM or IV. Okay, but never give IV bolus. Okay, you can give IV infusion. Okay, never give IV bolus. It can cause arrhythmia. Okay, so the side effect of IV bolus is arrhythmia, and also can cause water retention. Okay, instead of oxytocin, you can also use methergin. Okay, the dose of methergin is 0.2 mg IM or IV. Okay, maximum 5 doses. You can give a maximum of 5 doses. And the side effect of methergin is hypertension. Hence, it is contraindicated in pre-eclampsia and eclampsia. Okay. So the next drug used in the management of atonic PPH is carboprost. Okay, it's a prostaglandin. It is PGF2 alpha. Okay, the dose is 250 mcg. Okay, IM. You can give a maximum 8 doses. Okay, side effect of this drug is bronchospasm. Okay, bronchospasm. So it is contraindicated in asthma and also in cardiac patients. Okay, and the last drug that you can give in PPH is misoprostol. It is a PGE1, prostaglandin E1. Okay, the dose is 800 micrograms per rectal. Okay, side effect is fever is a side effect as it is a PGE1. Okay, so these are the medical management of PPH. So there are other certain tamponade method to control PPH. So the tamponade methods for PPH, atonic PPH. Okay, it include the first tamponade method is nothing but bimanual compression. Bimanual compression. And also you can use something called Beckery balloon. Beckery balloon. Or there is Foley's tamponade. Foley's tamponade. Okay. Now, if it is still persist even after the tamponade method, you can go for surgical methods. Surgical methods. So there are some sutures to control PPH. It is called, first one is called B-Lynch or brace suture. Okay. There is Chow square suture. Heyman suture. If it is not terminated with the suturing, you can go for stepwise arterial ligation. So for the stepwise arterial ligation, first ligate uterine artery. If it is failed, you can ligate utero-ovarian anastomosis. Okay. If it is also failed, you can ligate anterior division of internal iliac artery. Okay. And the other method is uterine artery embolization. And if it still persists, the last resort of management of PPH is nothing but peripartum hysterectomy. Okay, this is how you should manage a case of PPH. Okay, kindly consider subscription of my channel if you are interested in emergency medicine related contents. Okay, thank you.